Alaikum wa rahmatullahi wa barakatuh. Thank you for inviting me for this exciting conference. And as I said, it's cut to 15 minutes, so we'll go quick. So I have no conflict of interest, and I'll give a quick background about calcium and phosphorus homeostasis to understand why there are interest in developing parathyroid hormone analog for the treatment of hypoparathyroidism, and go quickly over the guideline. So essentially, if the parathyroid, as you know, secrete parathyroid hormone in response to low calcium and high phosphorus, and parathyroid hormone acts on the kidneys, and what does, it increases calcium reabsorption, so saving calcium, doesn't go in the urine, but it promotes phosphorus excretion. At the same time, it stimulates the conversion of 25-hydroxy D3 to 1,25-dihydroxy, the active metabolite of vitamin D. PTH also acts on bones, where it increases calcium release through the process of increasing resorption. Now, calcitriol, which is 1,25-dihydroxy vitamin D3, that is developed in the kidney, act on the intestine to increase the absorption of both calcium and phosphorus. And then the calcium suppresses PTH release, and 1,25-dihydroxyvitamin 3 also inhibits the gene transcription of PTH. And at the end, we get normalization of calcium and phosphorus and PTH. So in physiological term, something to remember, if we're thinking about minute-to-minute regulation of calcium and phosphorus, this is function of PTH. And it does it by its effect directly on the osteoblast and on the kidney. But if we think about long-term calcium and phosphorus regulation, this is a function of vitamin D, and it does it by enhancing intestinal absorption and PTH gene expression. I'm not going to go over PTH and PTHRB, just for the information. Parathyroid hormone is secreted from the parathyroid gland, whereas PTH-related peptide is made in many tissue, and probably it's acting locally as a local factor. There's a receptor of parathyroid hormone. I had the privilege that my team cloned that receptor many years ago. But the surprise, at the time, we were focusing on finding this receptor in bone and in kidney, because that we thought the target tissue of parathyroid hormone. But it turned out this receptor expressed almost everywhere, okay, in many tissue. And so the question is, what is it doing there? And when we talk about PTH deficiency, when it may have a wide consequences beyond calcium and phosphorus, and there are probably some specific function for different PTH fragment as well, which I'm not covering here. So the concept of replacement therapy, this is basic concept in endocrinology, is to provide the missing hormone to treat the deficiency. So we just spoke about thyroid hormone to treat hypothyroidism, cortisol for treat the hypocortisolism, insulin for type 1 diabetes, growth hormone for growth hormone deficiency. But when it comes to hypoparathyroidism, we don't do that. What we do, we give vitamin D and calcium. So the question is, the question is that enough? And in reality, we have a lot of issues about this approach. So we have fluctuation in blood calcium and phosphorus level. And most of the time, we may have hypocalcemia. So I'm following a patient whose calcium always in the 1.5 millimolar per liter, and just walk around like this. Every time go to the emergency room for something, they hold on him to give him IV infusion. He tell him, call the professor. They called me and said, this is chronic. He is not, compliant to his treatment, but there's no risk. Leave him alone. And so essentially hypocalcemia is very common, but also hypercalcemia from overtreating. Hyperphosphatemia, if not treated to target. We have a narrow therapeutic range which is required to prevent, to avoid hypo and hypercalcemia, and fluctuation are hard to manage. And we also have renal complication. Because of the excess of phosphorus and sometimes calcium, we get a lot of urine in the calcium. As I showed you from physiology, the parathyroid hormone actually cause reabsorption of calcium and reduce the amount of calcium in the urine. When you have calcium PTH deficiency, and we are giving calcium and vitamin D, we expect a lot of calcium will go in the urine. So what we are getting likelihood to have renal stone is much higher, and consequences also we get impaired kidney function. And we get soft tissue calcification. Calcification of the basal ganglia of cataract of the pineal gland. You can see it on brain imaging if we ever do it in patients who we are treating chronically for hypoparathyroidism. Quality of life, there's a lot of patients who say they're never satisfied, but this is hard to judge. So the question, can hormone replacement therapy using PTH or PTH analog correct the shortfall of the conventional therapy? And I'll describe the trial that use parathyroid hormone 1-34 for hypoparathyroidism. So you know PTH 134 is used for osteoporosis. And when we treat for osteoporosis, we give PTH one time, it go peak and come down, and then this apparently, it enhances bone formation, although it enhances bone resorption, but because of this kinetic, the formation is faster than the resorption. The net effect is actually bone formation. But to maintain calcium and phosphorus, that dynamic may not work. So this is multiple trial, but I will be talking about this trial, which this is it's called RACE. So this is randomized parallel group open trial. So I'll go quickly on it. So essentially, what I want you to when we talk about hypoparathyroidism trial, you will see the number in each of these trials is small, because this population is not large. We are not talking about hypothyroidism. We have, maybe a huge number of the population, like 5% in the UK, about 10 to 15% of all women above the age of 40. Whereas here we have few people to recruit. So and this has impact about our conclusion. Essentially, in this trial, which went up to 3 years, what you see here, the effect of PTH on serum calcium and compared to vitamin D, and the effect on urine calcium. So clearly there is some, and if you look at bone density, essentially the investigator concluded the PTH actually did good job on calcium and phosphorus, maintained it for a long time with less fluctuation, and they concluded that there is no difference between on bone density between treated and untreated. But I need to say these are PTH 134 given twice a day, and it's not the mimic of like giving once a pulse, and it has a chronic effect on bone. So in my opinion, for instance, here, if you look at, let's say, whole bone mineral density, and you look at forearm here, clearly there's differences, although not statistical difference because of the low number, but if you follow for a long time, chances are you may putting people with this schedule of treatment to develop low bone mass. How about 1-84? 1-84 is a natural peptide. By the way, when we think about parathyroid hormone as 1-34, we think 134 is actually a natural product of the gland. No, it is not. The reason 134 is used because the first person who tried to synthesize the 1-34 chemically, it could not do it beyond 34. So it stopped at 34. And when stopped at 34, tested in vitro and in vivo, it was effective. So we think 134 is a mimic but in fact it's not a natural product. It's just made, it was easier to make chemically. And if you look in the circulation for normal person, you will not find 134. You'll find 1-50, 1-70, etc., but not 134. So if we give 1-84, so what's happened? So also multiple trial here. I'm going to go to the latest one. And what you see here, So this is 1 to 84 again. The difference between this and the previous one is this given once a day, and there was two trials before that which were using 25 or 50. In this trial, they took whoever was 50 or 25, kept adding PTH, increasing the dose to reach target of 100 and see the impact. So what you see here, the calcium here this is the normal range, so it's normalized. And this is urinary calcium is coming down because PTH will conserve calcium. And this is, you see, dose escalation. So they started most of them around 50. And with time, so most of the patients became 100. And you see the number of patients. We are talking about 50 in this trial, less than 50, 49 and to 40. And this is 5 years. So it's very important because it's long, but it's also the number is small. And what you see here, serum phosphorus is also normalized, okay? And the calcium phosphorus product, which actually important for whenever we talk about substitute calcification, came down. And you change here what you are looking at, the calcium dose. So originally, so you see we reduce the calcium dose significantly by this management. And this is effect on bone. This is at the end of the, if you look at it at month 60, so I'm sorry, not bone, this is the oral calcium dose, oral vitamin D dose, and the number of patients who needed supplement, so here 27% and 55%, and number of patients who only needed supplement for both is 9%. So clearly we are able to manage the disease while reducing supplement, and this is effect on bone, very little effect on the bone, in fact. So if you see here, lumbar spine, no change, hip total, no change, hip femoral neck, no change, slightly reduced or maybe the 1/3 radius, which is the cortical bones reduced, but not significant. Again here, but the issue is, although it seemed like the recombinant hormone, parathyroid hormone, it could be better than the previous one. However, this medication is about to be discontinued by the end of this year, and the company could not keep making it because not enough market and not enough profit. So it's going to be ending this year. So there is a new drug coming in the pipeline, not yet FDA approved. The previous two medications were FDA approved, but this one is coming. So this is 134 linked to polyethylene glycol in such a formulation that actually end in releasing PTH at a normal temperature, 37 degree, and at pH of 7.4. At pH of 4 is stable. But pH 7.4, it released and with a half-life of a couple of days. So there is also several trials. I'll talk about the last one. Okay, so this is phase 3 clinical trial, and what you see here, the top here is the analog, and here you see the calcitriol dose, how it came down to almost discontinued. And same thing, the calcium dose. And they did a general health scale. This is, patient, let's say, experience and feeling, and so that seem to be improved, similar to control. This is supposed to be decided a few months ago, but that's going to be decided, postponed until August. We don't know if this most likely will be approved. Then, I'm sorry, what I'm doing. Okay, then there is a new drug, which is, sorry, it's me here. So it's a new drug, which is an oral human parathyroid hormone. This is a company that's making it. It's putting in the tablet soybean trypsin inhibitor and some other excipient, and it's allowing PTH to be absorbed in the gut and actin, so they're giving a huge dose. Now we're talking about milligram, not microgram anymore, to allow, and given 4 times a day in this clinical trial. This is phase 2. And what you see is normalized calcium as well and reduced oral calcium. However, I think this is, I didn't put the data, but there is some complications that coming with it, which is still early, this phase 2, so we don't know how far this will go. Parathyroid gland transplantation, this is a case that mentions the literature. This is a girl who have genetic hypoparathyroidism, and it turned out she had end-stage kidney disease. She required kidney transplant. Her father gave her kidney and 1 parathyroid gland. They give it, she was transplanted, and then serum PTH actually normalized, and and calcium came close to normal. So potentially you can do that, but this is not common treatment. So in conclusion, using PTH replacement therapy provide currently small improvement of symptom, however, most are short-term. Long-term use of PTH for hypoparathyroidism may be associated with long-term complication yet unknown. The small benefit may not justify the risk. The natural hormone 1,2-84 showed the best result, however, it will be discontinued. Alternative formulation need to be yet tested. And effect on quality of life, this is soft outcome showing some benefit, but yet not possible to recommend it as a routine. And so there is a Cochrane library tried to do, like a review, and in the review they put all the number, all the patients, and they concluded that we could not do a review because not enough data to justify the review. So I'll go quickly here. Okay. So essentially, this is guidelines published in 2022 in Journal of Bone Mineral Research. Essentially, still reiterating the conventional therapy. At the end, they suggest this is to be the first line. However, if it's unsatisfactory, the panel may consider use of PTH. I personally use PTH in few patients just because variety of reasons, not worked, with all of them, but in one patient did miracle. So I don't know. So here is a comparison. This is from the same. I just want to remind people that thiazide is a good drug to use in these patients because it actually reduces the calcium excretion in the urine, and that's a useful thing. Sometimes we forget about it. Okay, thank you.